Well, hello. Thank you for joining me
Hello.
today. I've got an I've got a really fascinating, interesting guest today that has been working on an area that is it's not talked about very much, and it's really crazy how little people hear about the importance of the tongue in terms of what it does for the development of the palate and the cranio-facial system, but also sleep and well-being and posture. And so I want to thank Dr. Chu for joining me today from Singapore. It's very early there, and so it's an honor to have you here.
Hi, Stephen. Thank you for having me. I think you have been doing a great job, getting all this information together for everyone. So it's actually my honor and pleasure to be able to be part of this and let's share our stories. Yeah.
Yeah, I really appreciate that, Dr. Chu, because you've got quite a big backstory, as to how your work has kind of developed and evolved over the years. But there's so many personal stories in there, and I just wanted to kind of help the audience understand, how a dentist like yourself has become, so focused on talking about the tongue, and it's not a well-known topic for most people. So, can you take us back to some of the original times when you were perhaps not aware of the work you do now, and what were the things that began to lead you into understanding how important the tongue really is?
Again, like I said, started with my own issues. I do have clenching issues. I grind and crack one of my tooth, right? I have neck issues, right? I can't pronounce certain words last when I was younger. I can't do the R sound. So like bravo, that I can't do it last time, right? So of course, nobody, even as a dental student, the topic of the tongue is just a passing subject, right? Where meaning that you just mention it, but no one pay attention to it. And as a dentist, I do see the same issues with my patient. So when I was in my 30s, really head neck pain issues and decided to go to US to seek help, especially to learn about neuromuscular dentistry, so that to understand how we can do a neuro cervical neck, muscular kind of rebalancing through the dental component. And of course, at that time, my mentor, Dr. Clayton Chan, right, really helped me a lot to relieve the pain. So I remember returning from Las Vegas. Yes, it's a 30-hour flight door to door, and then after that, I really get my pain again. But thankfully, in that rebalancing session, I took a lot of bites. After tensing and measuring the cranium and dental mandible position, right, it actually relieved. So from there, I start to realize, wow, our whole head neck alignment has everything to do with the body, and we can, as dentists, help to find that position in 6 axis. Later on, I keep asking the question, then why are we having this deficiency? And I think I have an inkling that looks it has this spleens in 6 axis helps to support the back end of our jaw especially. So who is not doing his job? So that is the tongue. So when that realization come to my head, I mean it's really helpful because it then become one of the central piece that I continue to search for an answer, and it guides me to many areas. And as Asian, right, I think I'm also exposed to this culture. Like for example, you learn qigong, you do tai chi, right? The breathing technique is all about tongue up. It's called 舌底上颚. So simply tongue against the palate breathing technique, right? And if you hear it from our yoga teacher, so they talk about prana breathing as well, right? Tongue up. So there's already this inculcated part passed on for thousands of years. It's just that sometimes we look at it as alternative science. It's just like meditation. It's just something mystical about it, but it's actually seeped in a lot of cultural and real medical, foundation. And I think through thousands of years of, experimentation in a way, just looking at the villagers, those with the mouth open, tends not to be that healthy, and those breathing well tends to be better. So then, learning about this, putting that together, and in 2015, this amazing person came to Singapore, Dr. Herman Ramirez. So he spoke about his work. Of course, he started with a bit of work with mild brace then, and his Planus track, kind of how we prop the bite up for children and manage the malocclusion early. And he put a lot of science behind the whole breathing and tongue basis for me. And from there, I think, yeah, it is so much easier to say, hey, where should I look? And ever since then, I incorporated it into my temporal mandibular joint disorder management for TMD cases. And then now that I'm more trained in dental sleep medicine with Tufts University, I think I also have a new level of appreciation of how the tongue plays such an important role. And also another very important period is 2016, 2017. I was in Taiwan giving a lecture, of course, tongue tie, among other issues, neuromuscular TMD issues for children and adults. And Dr. Marjan Jones, right, from Brisbane, was there also to give lectures about the babies, that the great work she's doing. And she highlighted to me, hey, look, why don't you get this part as well? Learn this, and you can be more complete in terms of the tongue management. And I did. And I went over to Brisbane to understudy and learn from her and Dan Hansen as well. So with a good number, and Jane Vidler, very, very important IBCLC at that time for me. So with the work with the babies, right, I say, look, it's really important. We brought this back. I assembled a team of IBCLCs who are willing to explore this further, and we even flew Jane Vidler here to Singapore to support them, to support me, right? So we have like 8 hands on one baby, or maybe even 10 pairs of hands, just taking care of one baby at a time. And we learn a lot from each other in the group. And ever since I've been, shall I say, for 2 years, I've been doing tongue tie releases for baby, working with IBCLCs, lactation consultants, chiropractors, osteopath, pediatricians, right, and functional doctors. And that also really gave me such an insight into what is the original factory setting for human, right? With the tongue up or tongue down. And while going through that process, I think the discovery of reflexes, all right, or should I say, for me, right, there's reflexes, saxilobreath reflex, there's cranial nerves. I think all of us as dentists and doctors, we have to learn about cranio-facial kind of nerves, right? So the cranial nerves, 12 of them, supplies to the face, to the jaw, to the neck, to the tongue, right, swallowing vagus, among all that 12, all right? How do they all come together to effect like a simple act of breastfeeding? So then I thought hard about it and start to realize, hey, yeah, I mean, it makes total sense. If the hypoglossal nerve is not firing, the tongue is not up, then there's a lot of compensation for the neck. The accessory nerve will fire. The trigeminal nerve will also open up your mouth with the face trying to coordinate. And then, you get into a very awkward posture just to make sure your cardiopulmonary system is protected. So you can breathe, at least stay alive. Not to mention, okay, maybe you can't speak that well, you can't swallow that well, but you're still alive, right? Yeah, so that itself also is a big light bulb for me. And digging deeper into that, I think, I sort of arrived at a very unique position that helped me to explain all this to my chiropractors, to my osteopath, and also to my IBCLC at that time. And then it make a lot of sense to me for my TMD issues. So that's why with a low tongue posture, breathing issues, and it can actually have 3 times more likelihood to get TMD from the study. And I say, oh, okay, that's why. And now that we're studying dental sleep medicine, right, again, the person not having a good tongue posture function, right, it leads on to a lot of sleep-related breathing disorder. So instead of trying to help them while they're sleeping, I'm thinking a lot now, right, about how we can actually improve the daytime condition. And free divers, with one breath, they can actually do the 8 minutes training. If not, they can do a 22 minutes record, right, in just underwater with one breath. How do they achieve that? So all that science behind it is very intriguing, and I'm still learning. I'm just a student, and hopefully, yeah, like I say, every one of us put our puzzle piece together, and I think we have a bigger picture of what it is all about.
Dr. Chue, it's so fascinating how you say it is this complex kind of, it's like a tapestry that brings together, how we function, with our airway, breath, development. The cranial nerve picture, it really is not discussed very well. I want to dive into that with you in a little bit more detail a little bit later in the interview. But I thought we'd first start off just so people can kind of get their heads around this. And by the way, we have a very international audience today. We've got lots of people from all over the world. So thank you for saying hello. And please tell us where you're joining from if you're watching. But Dr. Chue, I wanted to get a little picture as to how people are suffering from this syndrome. You just mentioned sleep disordered breathing, but what are the kind of easy to pick signs? And so, we mentioned breastfeeding babies. So what are the descriptions and the symptoms that you're seeing in parents and newborns that are suffering from these issues? And then how does that flow on to to older age groups, such as toddlers and as children get older?
Right. I think we look at the whole, again, like I say, I set up a clinic, and I call it the linguadontics clinic. Lingua means tongue, then dontics means dentistry. But of course, we changed the name for certain reasons. We'll explain that in maybe future stories. But it's a dental clinic, right, putting emphasis on the tongue. Right, so we are probably the first in Singapore, first in Asia, maybe one of the few in the world, right? As a dentist, specifically looking at the tongue, because no one actually took care of the tongue. So when we look at the tongue as a central piece, then you start to see all the related issues from infant to young children, adolescents, adults, and later on geriatrics. So as a baby, right, the moment we are born, we need to feed, right? Suck, swallow, breathe reflexes. Tongue up, right? Suckle, breathe, tongue up, and swallow, tongue up. So all this has to be a tongue up posture. So it's an organ that need to perform, right, with this contact bracing against the palate. So there's no other options. But if let's say we can't do it because of physical restriction, or because of conditioning for reasons like using a bottle teeth, a pacifier, and thumb, so the tongue stays on the lower position. And then for a child, especially with a physical issue, it's just like, in neurology, right? We've discovered that the brain supplies, signals to part of this body. We don't just go in and do a surgery and cut that away and just see what happened to the body, right? It's always from accidents, right? This person, a disease of this part, and yep, he can't move this part of the body. So over the years, we trace all this thing out. And like, true enough, over the years, many colleagues around the world, like for example, colleagues in SLPs, like led by like Esther Piacini, Irani Makasan, right? They worked so hard in Brazil to establish, this ability to just do diagnosis, to check on babies when they're young, firstborn, right? So newborn, should I say? So if we can establish that, then we can see issues like when the tongue is not up, they're not able to do the suck first, right? So when I assess it, the child is unable to seal top and bottom of the breast with the mouth, right? Whenever the baby needs to lift the tongue, there is a movement, and when it's suckle, right, because of the holding back of the lower jaw with a short frenum attachment, there's always a sort of a detachment from the bottom part of the breast. So there's always a click sound, right? Yeah, and you can see also the baby having a lot of issue trying to seal, and there's also leakage from the side of mouth, and swallow needs to transfer milk from the breast to the throat and then swallow, and you have to coordinate between breathing. So if there's a inability to also raise the tongue up and do an efficient swallow, it takes a long time to hold the breath, because you can't breathe and swallow at the same time, right? So you hold your breath to get ready to swallow, and you can't swallow. You hold your breath. The next thing is that you want to catch your breath, so you project out the milk. So they tend to have reflux or vomiting because of also aerophagia. They take in a lot of air, build up the pressure, and they vomit. And third one is that they tend not be they don't like to be on their back. Once you put them on the back, they make noise, and you have to carry them again. Oh, they are comfortable in vertical position. They want to be over the shoulder. They want to face down, right? Then you realize, oh, why do I have to carry the baby all the time? Because they just can't be on the back. The tongue falls back and block the airway. So the suck, swallow, breathe reflex give me a very good diagnostic matrix, right, to help not just looking at the physical state, because the physical state is not picked up by me. Sometimes it's by my IBCLC, my pediatricians. They send it to us, and we just do a final evaluation, and the discussion sometimes can take quite long with the family, right, to understand what is going on. And of course, when the child suffer, the mother suffer, broken nipples, right, the feeding time is extremely long, and they get hungry really fast because they're just not efficient feeders. They take an hour just to take a little, right, and so mom is not getting enough sleep, and of course then the whole family get affected. So from that stage, you start to realize that if a tongue tie not addressed, is not just the baby, it's not just the mother, it can be a whole family. So not only the diet that we actually address, but also whole family. As a child, right, the tongue is not up, they start to have maybe swallowing issues, some speech issues. So when we discuss this, initially some SLP, speech language pathologists, would diagnose.
Does this say age 3 to 4? So we just spoke about new. Is this like age more 3 to 4 now as they get a bit older?
Yeah, maybe even just two, two onwards, right? And it's just the terrible twos, and then they're running around and all. And also you see the transition is not so ideal nowadays, right? We used to wean them breastfeed only, right? Before World War II, there's only breastfeeding, right? Then we introduced bottle feeding and all this, but we have no better alternative, unfortunately. So we have to still seek of another better alternative in the future. But in the meantime, the bottle will be the mainstay. So tongue is being trained to stay low, and when they drink from a bottle, they have to they can't sit up, right? The flow is not good, so they have to lean back, and then now fluid is accumulating at the back of the throat. Your tongue cannot just do the usual up and back gulp swallow. You have to do the rationing. So you have to do, so you learn actually how to push the tongue forward for 2 to 3 years sometimes for a baby, and after that, right, they have tongue thrust kind of issues. And when they can't lift, be it for the reason of physical restriction or conditioning because of all this training, right? They're not efficient in, again, also swallowing big bolus of food, textured food. So they tend to eat very slowly. And then other things start to occur, right? They tend to open their mouth quite often, right? So just having an open mouth posture, incompetent lips, or maybe mouth breathing, right? That already set again another whole new condition for this oral cranio-facial area. The tongue stays low, because once you don't keep your mouth closed, the tongue is not getting the negative pressure within the mouth. The suction is not going to go up to bring the tongue up. So with low tongue posture, in my opinion, you can create two types of bites. So if it sits on the teeth a lot, right, it puts a lot of pressure to the back teeth, especially the molars, and the teeth starts to tilt in with a lingual. So we in dentistry, we call it accentuated curve of speed. So the teeth looks like that, right? And the bite gets deeper and deeper and deeper with the cheek pushing in. And then with the mouth open, the front teeth tend to flare out a little, right? or they can.
Just to clarify that, so Dr. Chu is saying that the molar teeth are actually pointing in. So the lower molar teeth, if you open the mouth, yeah, exactly, yep.
Yeah.
And so
the weight of the tongue, right, is on the teeth, usually on the inner half, right? So it makes those teeth tilt inwards. So you can actually see it in your patient as a dentist. And that creates usually more of a deep bite to me. Okay. And there are other way of putting the tongue right inside the jaw. Uh-huh. So then they tend to put the tongue in, and the lower jaw tends to grow a little bit more. And because the tongue never grow to stimulate the upper jaw, the upper is always smaller, even in the case of the class 2, right? So all that, right, if the tongue is right inside the jaw, I tend to see it's like a class 3-ish kind of development. So it's not like a true skeletal class 3 where the lower jaw tends to grow more, the prognathism, but it's really just a physical conditioning. So if we change the habit, such cases can go back to a normal class 1 bite. Yeah, I feel. So, and of course, they tend to also develop a lot of nasal congestion, from rhinitis to post-nasal drip kind of issue, even middle ear infection, right? And of course, the question is always which one is the chicken, which one is the egg. So parents will always ask that. So we just say, look, well, there's no harm testing it out. So why don't you get him to just breathe through his nose for a week or a month? They'll say, oh, but they can't breathe. No, I say, just try, right? So I have a patient, she's 78 now, and every morning she still spends 20 minutes breathing very properly through nose, alternate nasal breathing. Yeah, you know what I mean? All kinds of practices that, a proper breathing practitioner should go through, putting a lot of emphasis on the control and the smoothness, the lightness of breath. So we should practice breathing every day. That's how we can make full use of it. That's why the divers, right, the free divers, they are able to control many things because they really put in the effort to learn breathing, right, and able to control the diaphragm, and they communicate with the body to understand, look, if I do this, what is happening to my body, and when my body communicates back to me, how do I react? So only when you can get that conversation going, you have a little bit more control of what is really a breath. So breath work is very important.
See very commonly that patients just can't breathe. Last week I spoke to Patrick McEwen, who's written a new book that is a great textbook for dentists actually, and I'm looking forward to kind of dentists becoming more accustomed to this. But it's a very complex process in the body, isn't it? And most people just cannot breathe. They have no familiar kind of processes to connect themselves to breathing. So you're describing something that's very, very common. How would you say, Dr. Chu, that these? So we've mentioned newborns and then younger children. How do these symptoms change, or say a parent hasn't noticed these things? What about in older age groups, so 8, 9, 10, 11? What do we see in these kind of age groups?
Right. So at this, after 6 years old, you tend to see the adult teeth erupting, right? So ideally for the younger group, you should have gaps between the teeth. We know that as primate spaces. So I think you describe a lot about your, in chewing and all this, right? Just want to stimulate the growth and development of the jaw. So the tongue up helps. But then if they don't, right, the bigger size teeth, adult teeth is about maybe 1.5 times larger than the baby tooth, and they start erupting into enough space for only baby teeth, right? So when the adult teeth come through, they have no space. They start to rotate. They start to come out at the sides, right? So then you see crowding, and you see a lot of changes there. And the face tend to be longer now, right? Darker eye rings, right? The other thing that we have to be very mindful of is this, all right? Your upper jaw, right? Upper jaw is like this, right? It's from here, right? And it goes all the way to the back, right? So it's not just a plate on top, but it's all your whole midface. And this whole midface is happen to be also the floor of the whole cranium, the whole skull, right? So if you're not adjusting that upper plate, the palate, right, and widening it, you're also not doing anything for this piece of your face, right? And that is then mid-face deficiency, and breathing definitely gets into trouble because, right, you're not growing that whole arch. So I always say, look, your neighbor's upstairs, right? He's waiting for you to renovate your house. He wants you to open up the roof and ceiling, right? So that he is trying to build this pillar right in the center of the nose, the middle nasal septum, right? So it's sitting right on the palate. So if you open it up, this bone can grow down. Yeah, the whole base is widening, the whole volume is improving. But if we don't grow the jaw, and furthermore, if we use mouth to breathe, we tend to have a lot of cheek activity. So we're actually compacting things. We're making the palate even narrower. So the nasal septum is coming down and is blocked by this very high vault of the palate, right? And it starts to deviate, right? So then you get deviated nasal septum. And when you don't use the nose, right, there's no pneumatic pressure, right? You're not engaging the nitric oxide in the sinus lining, right? You're just not getting the best way to clear your nose. So then, as teenager, you get malocclusion, and unfortunately, sometimes as dentists, our training is just to make space, line up straight teeth, right? But we're not engaging and say, look, if we change the bite, will we change the cranium alignment, and will that change posture? If we change the bite and volume, will we change the space for the tongue to rest within the oral cavity? And if there's no space for the tongue, where is the tongue going to go, right? So you have to reverse park and block your neighbor's driveway, which happen to be the airway, right? Then you're going to go crazy about all that breathing issues. So we must respect volume. So as much as possible, we do expansion, and now I think in last year in the Journal of Sleep Medicine, so it actually highlighted that expanding the upper jaw maxilla for adults, for OSA or for any purposes, should I say, is it a myth or reality? And it's really stated that more than 10 studies support this kind of expansion without surgery to the sutures. So in my hands, I try to encourage my patient from young children to adults to engage in changing this habit, bringing the tongue back to the roof of the mouth, using the tongue as a very strong muscles, exerting more than 500 gram to 1,200 gram of force constantly while you swallow, while you breathe, while you rest, while you move, right, and getting the jaw to expand over again. So, okay, we might argue, say, adult we can't grow, but okay, remodel, whatever term you call it. But yes, we do see remodeling. And when they push the palatal bone and the alveolar bone, the upper jaw bone, right, to the wider circumference, then as a dentist, I can then line the teeth to the wider perimeter fence, right? So we have a wider upper arch, then the lower arch can be expanded and also come forward. And we adjust the back teeth to the right height, and we adjust spaces for the jaw joint. We adjust spaces for the tongue and the back of the throat. So we improve the condition for the person to breathe again, right? But a lot of it is in the hands of the patient. As dentists, we really can't expand the jaw. The truth is that it's the patient. So we can engage them. They understand what they need to do, right? We have a power team, and we're just going to be facilitators, and they're going to reestablish that. And when they can do that for themselves, not only just for the duration of the treatment, they're actually establishing a whole new lifestyle habits, right? And that holds the volume up, and all the bite gets more stable, and we don't have to worry too much about relapse if they can actually maintain that whole habit and function.
Dr. Chue, just on this topic that we're on now, there's a question just popped up that, because I think there's a little bit of misconception. Claudia asked, until what age can we remodel our bones?
As long as you're still alive, yeah. And even before 80s, your sutures won't close fully, right? And so in my adult patient, non-extraction orthodontics expansion, my oldest patient, I think, is 57 years old. Yeah. So we're working on that, and I've done more than about maybe 600 cases of orthodontic cases using Invisalign. Particularly why Invisalign is just that I can plan my cases and then make. Yeah, we have a good opportunity to help them to grow their jaw without taking out any teeth and still able to line them up. And there's a lot of attention paid to the alveolar bone, right? We want the bone to sometimes develop, and we try to get the root to come along, right? So that we do not create a dehiscence or recession of certain sort. So sometimes we just need a bit more time, not to rush the whole treatment. So using slow forces like this kind of aligners tend to be a bit more ideal as compared to using braces, where sometimes it's a lot uncontrolled. Some are controlled forces, some are not, right? And if you can't control the uncontrolled forces, right, that's when you get into a little bit of trouble when the tooth starts to move unnecessarily fast. So yeah, you combine it with aligner, stage by stage, aligner by aligner, expansion by expansion. So all my cases, when we go through orthodontics, the very primary thing that they have to do is myofunctional therapy. So it's a must. It's not like an option. So they do myofunctional therapy, and orthodontic is actually by the way. Yep.
And within your cases, have you seen an optimal time that you think this can be done for during the developmental period? Like, what age group do you feel that is kind of the sweet spot for kids to have this therapy?
When I, like one of my chiropractor with mine, say, I love you, you love me. So when your patient is ready to work with you, right? So yeah, if it's there's no, I think it's all developmental and cognitive development of a child, and also sometimes it's the family, right? So if they are very encouraging, they can guide. So I have a 2.5-year-old. I'm with her for a long time now, not because of anything, but she's just all the time. But that is, wow, amazing, that, right? We teach him all the function. He reads all about this, and he perform all these exercises with his princess, right? And yeah, so through that, we are able to get a lot of help for this young girl. Yeah, so there's no, like, say, age group. I feel that when as young as, like, my youngest patient is 4 days old, right? For tongue tie release. So now we're even looking, say, look, why wait until mom has a poor posture, and then in the pelvic is actually rotated, the baby having torticollis, and then delivered and having issues. Why don't you just set the mother right? So if you really want to trace, right, yeah, you can always even start with the this generation for the next. So the science is catching up, hopefully, thankfully, I would say, and many fields are coming together and looking at this together. So I feel that this is very amazing.
It's a really fascinating point you bring up, that we can potentially be planning for this before a child is born, which is really fascinating, right? And like you're describing fundamental aspects of a child's physiology and growth and development pathway here with like this part of the face. So it's incredibly important that this work continues to become more prevalent. Can you describe that? How would you describe the role of birth on this on a newborn's cranio-facial growth pathway?
Okay, I say ideally we go for natural birth, right? So I think natural birth, we've been doing it for so many years, millennium. I think it's like I say, they have to go through the birth canal in order to prime the spine. In that sense, the spiral rotation and all this helps in really activating. Our sutures are ready to compress, and our jaw is ready to, so we can squeeze through. So once we're out, breastfeeding is so important, right? Our upper jaw, lower jaw actually grew the fastest in the first year of our life. The fastest rate is in the first year of our life. So if you can activate that again also through breastfeeding, succinyl brief reflexes, a lot of activity going on, right? We are getting the correct amount of growth. And again, I say the microbiomes, again, just coming through the birth canal, you inoculate the baby with the right kind of bacteria, right? And that helps them to be stronger. And I think there's a lot of other parts to it which I don't claim to know, because I'm just again, like I say, just learning about this here and there when I talk to so many of my wonderful colleagues doing everything, right? So so once that is out, I think it's just uh, we can still continue to influence. So I have this opportunity to work with this osteopath, uh, um, um, Stephanie from University of Montpellier from France, right? So her work, she has 1 year out with the dental faculty, and she understands occlusion a little bit better than most osteopaths, and so she used her finger pressure, and she's already aligning, distorting the kind of jaws. Some so young children sometimes just okay, done. Okay, so that is all you need. Not a lot of force actually. Yeah, just that to get the jaw into the right place. Even clearing cross bite, adjusting the body. And when she treated me, is that her hands are like a scanner, right? Yeah, so she can pick up like where are the distortion, where are the tension, and where she should put in a little bit more. So I mean, the art of healing. This is art of healing. The science of healing, right, is coming together, and we now learn to more appreciate, some fundamental principle of how humans should grow. So again, like I say, the argument is just that we had it rough, we had it tough, right, last time, but that made us, right, yeah, human. So if we go light on things, chill less, and less active, not being upright, always sit more than we stand, right, and all that, even just talking too much, we are in trouble. Yeah.
It changes the posture of the mouth. It's such a complex area. It's so, and I think you were talking about there the intraoral manipulation that an osteopath is doing to help the growth of a newborn. It's fascinating how detailed this can possibly get. And you mentioned that there is an ancient art, that I love, that that this has been talked about for thousands of years, and that our ancestors knew how to facilitate this growth. Yet, we've kind of been disconnected to that. And so the science, it really does explain it quite well. And you talked about it in your TEDx talk, the role of cranial nerves in breastfeeding. And so, it's really inarguable how important this is when you just follow the anatomy of the cranial nerves. Do you want to just take us through, kind of an explanation of what the tongue is doing during breastfeeding? Because I think that helps to for people to picture how critical this is and how they should be thinking about it all the time, not just in growing and developing kids, but now today. I'm focusing on my tongue posture as you're talking, Dr. Chue.
So yeah, I think it's such an important organ. Again, I say it's underrated, right? But unfortunately, if you talk about it, yes, we know that ENT manage the tongue sort of, but it's like they manage the tongue by the way, right? Not that is with focus. And of course, things are changing, I must say. So with the tongue as a baby, suck, swallow, breathe, reflex, tongue up to create this very ideal situation to activate the breastfeeding technique, or should I say breastfeeding procedure. Okay, so first, the baby is just like, they can't even open their eyes that much, they can't see. But the moment they feel the nipple on their face, right? So trigeminal nerve, facial nerve, right? All this start to feed signals to the trigeminal nucleus. So it's just like gyroscope and a sensor that tells you the position of your head, temperature of your head, and all that. And okay, so when that detects, so the baby knows that, okay, it's over here. How do I get there? So the signal pass on to the spinal accessory, which is the 11th nerve. So the wire, so just now activating 5th and 7th, and then now you get your 11, right? 11 fires, then you turn your head. Okay. Then now your 5th trigeminal opens up the jaw again. Your facial 7 open up again. Okay. Then you do a latch. So once you latch on, well, okay, then your tongue which is hypoglossal 12, right? So it just okay has to go up, and then has to start to do the very rhythmic movement against palate, it's like aloha dance, right? So you can't do it like randomly. Everything in its own segmental way. It cannot be. It has to be all totally synchronized down to the milliseconds so that the seal is done, okay, and transfer to the glossopharyngeal controls your pharynx and larynx, right? And then your vagus nerve, like number 10, has to go and control your breathing. Stop it first, right? Allow for you to swallow, reactivate breathing, right? Slow down your heart rate and activate peristaltic movement. The parasympathetic system is very active now, getting your whole parasympathetic and peristalsis going in the internal organs, secretion of of the glands and all that to coordinate properly, right? And then you complete the whole transfer of milk, right? And of course, at the same time, the baby is he can't really see, but he still can figure out this dark spot. So that's why for the ladies, the areola, the teeth of the breast become darker, so it's a better target for the baby, right? And olfactory nerve, right? So obviously they can pick up the scent of mommy, right? So they feel a sense of safety. They can relate, right, through also the vagus tone, right? They can relate, so they feel very calm. They're ready to feed, and then even the vestibular cochlea, right? So even if you put the baby on the tummy of mommy immediately after birth, they can sort of wriggle, climb their way all the way up, and then go onto the breast and feed. So the balances system, right, if is still there working, so that they can actually do that. So all 12 cranial nerves are active, right from birth, and if they're not, when, right? So this is ongoing, and when they start to eat and chew, same thing. Mm, yeah. So when you're even having a conversation with a friend, you don't even think about it. But when you're chewing, a trigeminal nerve firing, facial nerve coordinating, right? So there's always the we call somatic part where you can control, or you have the visceral part where you like, the sudden thing that comes from emotion, right? But they are always coordinated, right? So you can sometimes control, sometimes it's just in natural response. But again, it has to be coordinated. So coordination of trigeminal, facial, your tongue, hypoglossal, when ready to swallow, vagus, glossopharyngeal, even accessory. Imagine you're trying to eat like this, right? Or hang a head up there. It's very hard to eat, right? And chew, right? So that fires. So your eyes, if you close your eyes and eat, and compared to you like sitting down properly and not having to float, right? Everything helps, right? So all that 12 cranial nerves applies again when you're chewing, right? So they're always there to do that little. So when again coming down to sleep, right? If the hypoglossal nerve is not firing, not up against the roof of the mouth, you can't breathe. So your body say, okay, jotomate, right? Wait, let's do something. Open the airway, please. So what do? You fire accessory nerve and go forward head posture, and then fire a trigeminal to open the mouth. Facial. So I can breathe, but 3 wrongs doesn't make 1 right, right? So all that is compensation, and again, the upper jaw needs the tongue to give a very good reference. The tongue only knows the center. It's a deep front line, right? It's connected from all the way from your toes up to your psoas muscle, to your diaphragm, to your mediastinum, right? All the way to your trachea, and then your tongue, right? So when the tongue is up there in the center, it actually centralize your internal part against your spine. Right, and then it opens up and align. So it's just not it's not physically, structurally only, but it is also neurological in nature, in helping to just make sure everything is in good position, right? So when you keep the tongue up, you support the upper jaw. Remember, we talked about upper jaw being part of the cranium. So with that little hint, I'm going to test this thing. Can you move your lower jaw? Can move your lower jaw? Yeah. Can you move your upper jaw?
There you go.
Okay, I'll tell you how. Yeah. Yeah. So when we want to eat a burger, right, you do go. So there's a 50% up, 50%
Mm.
down.
Mm.
When you want to yawn, so
Yes,
you,
yes.
you so you open the mouth by lifting your upper jaw. So to lift the upper jaw, you have to actually tilt your head. So in
Right.
that sense, to me, the TMJ is here. Then the
Mm.
upper jaw happen to also have an articular joint. It's the AOJ, the article, atlas atlanto occipital joint. All right. So because of this, yeah, upper jaw is connected to this joint. So when you control the upper jaw orientation in 6 axis, you're actually controlling your head, neck, cervical alignment, right? So then, of course, it has influence down, and of course, what's happening below has influence up again. So we need to look at the true path, top and down.
It's fascinating when you look at the simplicity, well, the complexity and simplicity of how this system works. Like it's quite, it's very, very detailed anatomy, what you're describing very simply for people. But it really shows how, what the body is really focused on, right? If humans design with 12 cranial nerves, the body specifically put these things there for a very important reason. And I was actually thinking, it was a while ago, because I was looking at these cranial nerves, trying to do a similar thing as you're doing, is trying to explain it as to why we have it that way. And it just didn't hit me why spinal accessory was there. I was like, why is there a cranial nerve for spinal? Because it just seems like it's, because there's so many muscles are hypoglossal, but that makes complete sense, because it's another cranial nerve that the brain has to have close attention on to make
Yeah.
adaptations. And the forward head posture makes a lot of sense, right?
Yeah. And you used to have a call a spinal accessory, and also it's actually, if you look at all the cranial nerves, the 11 is connected to the 10, right?
Mm.
So they're and they're connected. So they're always like all firing, and the vagus has a phrenic nerve that goes to the diaphragm as well, right?
Yeah.
Yeah. So you have an infra and also the sub diaphragm. So my point is just that if we limit ourselves to anatomy and try to understand things, the dentist will only given this, and sometimes we're given the tooth only, right? Then how on earth are we going to settle the problem? But so that's why, when I start to treat my own problem of joint pain, headache, neck, shoulder aches, hip pain, right, grinding, airway, tongue, swallow, speech, right, then you start to say, okay, look, right, where are all these things coming from, and where it goes, right? And so then you see the running of the anatomy of the nerves, right, beyond the cranio-facial, sometimes even, if not, at least you see the whole engagement. Even the trigeminal nerve, it has a branch to the dura of your brain. So that's why when through chewing, you activate your brain flow, all that whole flow. You actually get more quick response. So there's a lot of coaches when they're giving, looking at the game and having attention, they chew the gums.
Hmm.
So they're like they're thinking. So they're getting a lot of blood flow to the brain while they're doing that. So you see, there's a lot of relationship in all these things. So if we understand the use of the nerve, right, and what it's actually doing in conjunction with the rest, I think that we can take a lot of from them, rather than in school we just have to remember where it runs and where it ends, and that's it. We just return it to our teacher by the time we finish our exam. But if we understand this, wow, man, it's like every single day, every single moment, you understand how the body is trying to compensate. So sometimes I don't. For the lack of the word is that it's not dysfunction, it's not cranial nerve dysfunction. They're actually doing their job. They're just doing cranial nerve function. But the problem is that they have to do certain things that is not ideal, right? They just want to keep you alive. The main thing, keep you alive, right? So if we can just put the tongue back up, a simple act of just putting the tongue up, bam, right? So we influence it from a cranio-facial, right? So we look into the gastrointestinal, so the swallowing gets better. The whole head neck alignment is improved. Extension of the cervical spine. Your brainstem become the spinal cord. It runs through more, unobstructed. The nerves, cervical nerves, like brachial plexus coming out from the neck, right? They don't get pinched when your forehead posture roll over shoulder, and you don't get that impingement here, and you get numbness or even pain in the fingertip. tips, right? And your reaction time is much faster, so you don't compensate because of the kinetic chain being broken with a forehead posture. Then you induce lumbar curve and pronation of your knee, flattening of your foot, right? So all that is not happening because the tongue is back up in the right position. So, and if it's so simple a device to use, why not train to use it properly? So of course, like I say, I used to use expanders as well. So we want to put an expander in, but I'm always saying, look, we have such a wonderful expander in the form of the tongue. Yeah, if we can just engage it early, right, it will not stop acting for you and working for you in the right direction for the patient, not even for me, right? So if we put a bit more effort into training it, right, the patient will have a lifetime of benefit with it.
Yeah, totally agree. The orthopedic expanders certainly have a role, but the tongue is absolutely the day to day, and it's every time you swallow. I always try to get my patients to get back to this postural connection every time they swallow, and it's very foreign for people. It's something that both practitioners and patients aren't aware of. I think one of the biggest disconnections, Dr. Chue, is the connection that you described between the maxilla and the cervical spine. So all these postural connections and issues that people have, they're not connecting it to what they do in the mouth because it hasn't been explained very well. So I thought you could explain that 6-point connection, just so both the practitioners and the patients can understand why this is so important.
Okay, so when the tongue goes up to the roof of the mouth, right? We look into translational rotation kind of problem. Okay, so the rotation part will be like a plane. You have the pitch, the front end and the back end pitching. Okay, so from the sides you'll see roll, right? And then also there's the yaw, right? So this is the rotational, and then translational is just like up and down, front and back, left and right. Okay, so in order for us to start treatment, so you want a face bowl, right? So upper jaw face bowl, but how to get a reference? So you reference it to the floor, right? Horizontal plane. You want your Frankfurt plane starting from here, right, all the way through, and then the canthus and across, right? You just want it to be horizontal. So one of the ways that I get that in my patient is I get them to sit on my Sally chair. So it's like a saddle chair. So when they sit on saddle chair, right, we can get a very very nice pelvic roll, and it's actually sort of like get the spine upright, and I get them into a more relaxed position. Sometimes they still have the head tilt, so I just have to get them a little bit, and then I'll just try to let go and help them to get to the neutral. So in that way, I'm just trying my best to level off the maxilla first. Okay, so to level off maxilla, I'm actually manipulating the the COC1 AOJ. Maxilla, then you go into your basilar bone, and then into your sphenoid, and then to your occipital, and then later on to your allantoaxis. So this is one area. So once we level off this component, then I start leveling my jaw. So we get the patient to stretch and relax, and we do tensing. So all that, right? Even sometimes just a cheek retractor also is helpful. Just we control the what I call the engram, the muscle memory of the bite. Okay. So we set the top. Okay, right. Okay, right pitch, right yaw, right roll. Okay, then we set the lower. Okay, samely. Okay, then we get a neutral point. Right. So now when your two bases, upper and lower bases, are more or less in harmony with the whole body, okay, then we start to decide where the teeth should be. So they can be adjusted with orthodontics, prosthodontics, even just sometimes just restorative, right? Or simply if we start earlier, we get the tongue to help. Right? When the tongue is up against the roof of the mouth, the lower jaw is directed. When you close the mouth, there's an AP, anterior posterior referencing, right? Okay, your lips. Then your tongue goes into the roof. Then you have your Yeah, like a car jack at the back of the, and then jack, 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 jack. Then you get into this horizontal. All right. So you have your front now, lips, not teeth, referencing. You have your tongue referencing. So now your lower jaw, unlike the mouth open tendency where it's like a little boat lost in the open sea. It can be here, it can be there, it can be yeah, from everywhere. So and when when that is the situation, the lower jaw tend not be in the right position, and they tend to function also in a not a very nice trajectory when they open and close the jaw, right? Then you induce changes to the jawing, you get clicking and all. So my TMJ patients sometimes, they always complain of clicking, right? And you can just do a simple experiment with them. Just ask them to put their tongue up against the roof and ask them to open slowly. No more clicks. Yeah, there's no more clicking. So, when the tongue gets up, the trajectory becomes smooth into the right place. The back end is actually pushed open because of the jacking of the tongue, right? So the condyle is not ramming against the fossa. It's actually brought down, right? And the lower lips and the tongue also bring your jaw forward into the neutral position. Then the teeth, like I say, then will be set in the right way, and everything will coordinate well. Yeah, so that's how important the tongue helps to orientate the upper jaw, orientate the neck, or we orientate the neck to orientate the upper jaw, and then we reference the lower, and then we work on the teeth.
Just for those listening that aren't familiar with where their tongue, so you've described how important this is overall, from a practitioner's point of view, which is just fascinating. But the for people that aren't familiar with this, how would you describe to them, like, how to correct their tongue posture, in simple terms? Yeah.
Yep. So I would start just telling them, like sometimes we talk about the end spot. So you will say and is the tip of the tongue. Then you slowly work your way. So you start with the tongue touching the roof, right, of the mouth with just the tip, and eventually you want to work the back end to really come and become really nice and tight against the roof, and with the tip, the front part actually coming down that little. So we start with just the simple tongue touching the roof, and when I ask them to do so, I don't want to see any extra action of the facial or the cervical area. Just to get
the eyes. A lot of people use their eyes with it.
Yeah, all those things. No. I say, look, just keep it simple. Just put your tongue up. Okay. And so tongue clicks. So sometimes, I don't want to make it too difficult. And I have a colleague in Germany. I find that she has a very good. So she has this little strip. Yeah, it has 3 spots on it. So it's good that you put it in and you sort of almost swallow it. Then you sort of can feel that you're touching the first dot near the tip, or you're touching the second dot near the middle of your tongue against the palate, or you're touching the back dot, which is nearer to the soft palate. Yeah. So in that way, you can get a good idea of the referencing, or hopefully maybe we'll develop some technology as well. So helping patient to detect those spaces, and then work the tongue to reach and be able to just comfortably, not with force, to touch the roof of the mouth. But again, before we can get the tongue up, the truth is, right, if you don't get a good lip seal, you're always planking the tongue up. You can't last a whole day. So lip seal, create a negative pressure by swallowing, drawing the air out 1, 2. Then you get negative pressure, the tongue gets up there. Right. So start with the lip seal, right? Then you can get tongue up for a long period. And then once their mouth closed, they breathe through their nose, right?
It's a great tip. It's training those. A lot of people, I find that they get very tired in the back of the throat trying to get that backwards connection to the soft palate. But if you just get into correct facial posture, it starts to do it itself, right? A little bit. Once you become familiar with it.
Yeah. So it's like, say, influence either way. So I have this patient just so I said is my friend. I talked to her, and she then got her son to actually practice it, right? And he has been open mouth for 14 years. And you can see a narrow arch. And the moment mom highlighted that he needs to put his tongue up and the moment his tongue is up, he can close his mouth. Yeah. So because when the tongue is up, your jaw goes into a more central space, then it's even easier for the lips. If not, when our mouth is open, sometimes the whole jaw rotates backwards, right? So you have retruded, and then it becomes harder. Or the other way is true as well. So I think they're all helping each other to find their places in 3D space. So if we get all the position right, the neurological and the structural feedback will help us to then get it right.
Dr. Chue, there's so much to this topic. We could go in any direction, but I think one of the biggest symptoms people probably experience due to poor tongue posture is snoring and poor breathing at night, right? Which we discussed a bit. How would you tell people, the influence of changing their tongue posture in snoring? We described it, but for those that kind of have a family member that snores or a child that snores, how would you describe what's going on when they sleep?
So I have the again, I say pleasure and honor to treat young babies. So I have a video of a baby, mouth open, while awake, on his back, he's snorting and snoring, trouble breathing, and he has to turn his head immediately to the side. Okay, compared to another baby, lip seal. Then we open the mouth. You still see the tongue up, right? And he's like the calmest dude in the room. And he's still sleeping with the mouth closed and no airflow through his nose. So it's like, wow, okay, now you have these two babies juxtaposed against each other. Then you start to realize, look, I don't want to open my mouth. I don't want to be the first baby. And for anyone, right, if we don't put the tongue up, they don't realize where the tongue is going to go if you don't. There's no such thing as tongue up or tongue down. It's just the tongue is in the mouth. That's it. Done. All right. But when we can illustrate to them, there are many videos now, and there's some animation even done by Dr. Herman Ramirez. All these are helpful to explain what happens when the tongue is up, what happens when the tongue is down. All right. And there's cine MRIs that we can actually see. So that gives the patient, oh, you mean I'm only looking at the tip of the iceberg? There's a whole part of the tongue underneath. It's almost the size of your fist, You have to fit this in there. And if it's not up, it's down, it's back. Well, it's just blocking the airway. So again, I think the emphasis is there because the research is going on. 2015, there's a systematic review meta-analysis published, right, Stanford, and highlighted that myofunctional therapy improve AHI by 50% for adults, 62% for children, right? And the most recent paper published Sleep Medicine actually is in August 2020. The role of myofunctional therapy helps with obstructive sleep apnea for children. In this meta-analysis, it showed that despite the differences in exercises, all right, it still improved a mean of 43% reduction in AHI for children and improve saturation of oxygen, all right, in the blood. So simply by just getting the tongue exercise right, closing the lips, having a proper swallow and breathing through the nose, these four areas, lip, tongue, swallow, and nose, right, we can solve almost half of the breathing issues, in children and also probably in adults, half. Then the other structural component, it takes time to develop, but once you start, either it's actually through a surgical or through pharmaceutical or through dental occlusion, expansion, right? All that can add in. So some of my, also my Invisalign patient, the moment we expand the upper arch, they can breathe better. Even for myself, I have a deep bite, which I'm also going through Invisalign treatment now. It's never too late, all right, okay? So I'm trying to expand and upright my teeth to get more vertical support at the back, right? And the moment I put my aligners on, my jaw can really reference to a more forward position, just because of the way, my teeth can engage better forward. I sleep better, my neck ache goes away. And if I don't wear my aligners, right, neck aches will come back. I used to be on my orthotic for 5 years too. So a lot of things I saw, like, bum here, bum there, I figure out it. So I figure out how I can measure the bite, like what I explained to you earlier, and decide where it is. I scan, I send to Invisalign, and they'll send it back to me and say, "Sorry, doctor, your bite is wrong." I say, because the teeth, the jaw is floating in air, right?
Mm.
So I say, no, it's not wrong. I already determined the six axis. All right, keep it there, please. Thank you very much. So even I have an opportunity to fly to Costa Rica, and I spoke to Jason Ramos, head of. So I was even next to my technician in the big hall of computers, telling him sorry why I actually put him through all kinds of funny requests. The reason is this, and thankfully also they are into the development of MAF right at the time, the mandibular advancement feature. So they figure out what I'm trying to do very quickly, and now it's a non-issue. And I have a very honored opportunity to actually present to the CEO, Joe Hogan, the C-suite, and also the 20 regional managers of Invisalign when they were in Singapore. And as a general dentist, talking about Invisalign to them, why, right? They just want to know things that they don't really already know, right? Or not a usual application. What else I use Invisalign for? So that helps. And from there, I got myself a job. So I become a consultant for Invisalign HQ, join in a very secret outer program. So for 2 years, we designed the new platform for Invisalign. So the new color scheme and all those things that you're seeing now for Invisalign, clean check. I'm honored to say that I play a role in voting for the black scheme and not the blue one, right? Then now they're also asking me to engage in another project, which they are going to detail out all my thinking process of how I move my teeth, right? And they want to systemize it into an algorithm. So eventually, I will be an avatar on maybe in the cloud, and dentists will be eliminated because we have 9 million database and it's growing, right? And they know what works, what brought the tooth to the right position and what didn't, right? After a while, they just figure out, you just need to scan, and the computer will be the best orthodontist in the world to decide what is going to work. So, but again, like I say, the objective is still important, right? You have to set the right landing spot so that then you can move the teeth to the right place that is supporting the whole cranium musculoskeletal system. Yeah, so and neurological system, respiratory system, right? So you want that to be the best. So cranio-facial respiratory complex is now the new, like say, key term when we deal with this whole area, right? So yeah, our role is expanded, and if not, like I say, is more important than ever. So as dentists, I think we can help. As dentists, we can. Pardon me saying this, that we can destroy as well. So I think we hold a lot of responsibility. So in our hands, yeah. So we have to really dig deep to do this properly.
It's fascinating work that you've done, and I must say it's very difficult what you've put together, like, because all the different aspects that you've placed, they're really very disparate, from the literature to training. So it is highly commendable what you brought together and what you're bringing forward as a system, because this is very difficult work, Dr. Chue. So I have to thank you for that. We're coming to the end now. There's been a lot of questions because obviously your knowledge is very valuable. But just connecting this back into kind of how important this is for systemic health. Kiko asks, if a mouth breather can change to nose breathing, can gastric reflux of the esophagus be alleviated?
Yeah, I think so. The key point is that, right, when we swallow, right, the tongue goes up to the roof of the mouth and activates the swallowing center in the medulla, and then it sets forth a whole series of events. Then you start to have peristaltic movement, bringing things down, and your sphincter, right, so in the whole gut area, especially in the gastric, right, will have to open up, and let things in and close, not to let things out. All right. So in a very strong should I say a strong parasympathetic system, when you are nose breathing and you're swallowing well with the tongue, yeah, is being activated. The vagus nerve is activated. The parasympathetic system is activated. So you have a very healthy gut going on. So again, when I say the discussion of microbiome in the gut and all this function of the gut must start with swallowing. because that's the beginning of the whole gut, right? It's not just what is inside, it's what we feed inside. All right. So, and the neurological component. All right. So now when the tongue is doing that well, right, you have very nice peristaltic movement, your strong, smooth muscle tone, right, holding and closing it correctly. That's ideal. But when you do mouth breathing, the swallow is impossible, right? No, to just open your mouth, and then when you want to swallow, you close your mouth and put your tongue up, and then you swallow correctly, and then come down again. It's just it won't be the case. So the tongue decide to just do it quick and fast. It just swallow like this. Yeah. So when that happens, it's actually not activating the parasympathetic system well. But the big problem is at night when you sleep. All right. So with the tongue down, blocked airway, breathing is an issue. When you're now on your back, you're gonna go. Okay, then you're going to shortage of air. You're not going to stay in sympathetic or calm state, right? You're going to go into let me do this. You're not going. Okay, so you're short of breath now. So you're not going to be in a calm state. Parasympathetic system is off. You need to go into your fight and flight state. So your sympathetic tone is up. So it's just like, you watch those movies when someone whip out a gun and aim at a guy and going to shoot him, he pee in his pants, right? So what caused him to pee in his pants? It's just this sudden let go, right? Right. So the thing is that the internal visceral system, lack of parasympathetic control, sympathetic control is weaker, your sphincter control is weaker, right? And at the same time, there's a lot of airway breathing that needs the diaphragm to help to pump. Then you're actually lying down, right? And the diaphragm is pumping, and intrathoracic pressure also is very high. Then you're sucking, and there's a negative pressure in your throat. You're getting all that backflow of gastric juice coming out from the stomach and up to the throat, right? So once you practice your tongue up breathing, nose breathing, right, you sleep like a baby, then your gastric reflux is gone.
Dr. Joe, I'm so glad that you described, a gut issue as primarily being, part of how we posture the tongue, because there is so much conversation about systemic gut issues, and no one is connecting it to how we posture the mouth and how we swallow, and the cranial nerves that govern it. So it's absolute, it's straight anatomy that we understand this, and you've just described it in perfect sense how gastric reflux happens through a poor an imbalance between the timing of the muscles and the posture when we go to sleep and so forth. It makes so much sense, and it just shows how simple this work can make other problems. I found that people that when we solve issues here and we understand them from the very simple terms that the dental arch and the all of the things we learn in the mouth, the oral system connection gives us, it just makes things so much simpler. And so you're living testament to that. And I have to thank you very much for that.
You're welcome. You're welcome.
And look, we've run out of time now, but there is so much to this. We'll have to do this again because you're a wealth of information, and I've got lots of questions myself too. So, but I have to thank you so much for your work. The work you're doing is so important to forward this conversation in how we understand this system. Where can people find you, and what do you have planned in the near future?
Okay, so definitely, like say, when I used to fly a lot, almost like two or three times a month, going to learn and going to teach. What I worry most is that it's not me being dead, it's my information being lost because this hard disk is not backed up yet. So we'll try our best now to put it into lectures. So I've recorded 3 parts that is now being broadcast already in Japan. My colleague, Dr. Abe has already translated this, and I'm glad that it's being shared with some doctors over there. I'm putting it even more concisely in Kajabi, so we're going to share this to more people, right? I'm working with educators now to also go into the area of how we can improve children in cognitive and sleep ability to perform better. I think Facebook is still the easiest way to get to me, right? Hopefully, I'll share more information on how Kajabi can be the next area where you can find even more detailed information. I have my TEDx talk as well. Now you can find on TED platform, and I go on Clubhouse too, and then yeah, and on
The website linguadontics.com.
Yeah, so linguadontics.com, yes, we're trying to revive it as well. Now it's taking all the you fill it up, you have your connection. Then once we get all these things all set up, yeah, we're going to broadcast in a big way. So in the meantime, I thank you so much for giving me this opportunity. These are also these very valuable channels that we can share our information together. So thank you, Dr. Lin, for this opportunity.
Well, it's been my pleasure to talk to you, Dr. Chue, finally. And yeah, I think there's going to be many conversations from here. Thank you again for your work. And yeah, I look forward to hearing all about the future, because it's exciting that this stuff is going forward. So Thank you, Dr. Chue, and I hope you have a great day being up early in Singapore.
Thank you. Thank you so much for having me.